All right, got a couple cardiovascular topics. I called it potpourri because I wasn't sure how many topics I was going to do, but it's really just anticoagulation and antiarrhythmia. And some of the stuff we're going to go through pretty quickly because I don't think it's terribly relevant to your practice, but there are some things I'll focus a little more time on. Starting with antiplatelets and anticoagulation, really with hemostasis, you have two different components of blood clot formulation. And there's a couple different ways you can have it. You can have a trauma or injury induced, which causes some sort of response in the body of clotting factors and platelet aggregation. Or you can have blood just stopping. So if the blood's pooling somewhere, you can end up with a red blood cell rich clot. And so what happens is, if you want to think about it this way, venous thromboembolism, which are going to occur, deep vein thrombosis, or pulmonary embolism, those are going to be factors of blood pooling somewhere. So the blood's usually pooling in the lower vasculature, and that's where your DVTs are coming in, and then usually moving into the lungs, which is where you get a PE. Or if you have atrial fibrillation, the blood can pool in the atria of the heart because they aren't beating appropriately. Trauma or injury induced usually comes from people who have plaque buildup in their arteries. So the typical myocardial infarction is this way. So you have a plaque buildup in the arterial wall. Eventually it bursts through into the lumen of the artery, and you end up with platelet aggregation and response there. So show you a little diagram of this, of what a blood clot normally does look like. And this is using a plaque as an example. So most of your patients probably are going to be young enough, unless they have a pretty significant genetic history of cardiovascular disease, probably won't be at risk for coronary artery disease, but it is possible. So, but this is just an illustration to show you how things work. So if you have plaque buildup in your artery, eventually that bursts through, and platelets immediately come to help heal that area. What happens is fibrin recruits red blood cells and forms a clot there. Ultimately, because that artery is so constricted already because of the plaque, you end up with a blockage, and that's what causes a heart attack. Same thing can happen in the cerebral vasculature as well, causing stroke. Very different mechanism from what happens with like a venous thromboembolism, where there's just blood pooling and you end up with a clot that moves into a smaller vessel that ends up occluding it. Usually not life-threatening, unless pulmonary embolism, depending on how large it is, can be, but a DVT generally is fairly easily treated as an outpatient, but we'll get to that in a minute. Okay, we're going to talk about platelets really quickly first. So really, if you have compromised integrity of your vascular lining, platelets will be exposed to collagen fibrils, and they'll be provided with the surface to adhere to the vascular lining. And then what happens is, once that one platelet or two platelets or three or however many start adhering, they have signaling mechanisms that recruit other platelets. So it's called platelet aggregation, and they kind of adhere to each other and cause a clot that way. These signaling pathways also recruit red blood cells, which have clotting factors and so on and so forth, causing a more stable clot to form, hopefully so the body can heal itself faster. The platelets have about a 5-day life cycle, so if you have anyone on aspirin or an antiplatelet drug prior to delivery of a baby or any type of surgical procedure where there's going to be blood loss, you want them to be off of it for at least 5 days. Usually we say a week to be safe, but it just depends on the risk of the surgery and whatever. But usually 7 to 5 days is fine. This is just a diagram showing the different receptors and how they interact with the damaged area of the vasculature. So these are platelets, these yellow things, and they have different receptors here, which I'm going to talk about in a minute. The major drugs here are going to be our aspirin and our P2Y12 inhibitors. The rest of these I really don't care about. There's some newer drugs that are possibly on the market, but nothing has been up yet. There's these GP2A, 3B, which really only work or only used in cases where people can't take an oral medication and it's a really acute, like an acute heart attack, they might use these in, but we aren't going to talk about those. Different drugs working on different areas. So we have our P2Y12 inhibitors working over here. And then we have our aspirin working intracellular. Aspirin is a form of an NSAID, so all non-steroidal anti-inflammatory mechanisms or anti-inflammatory medications work on the cyclooxygenase enzymes, which have a production pathway of prostaglandin inhibition. But upstream, aspirin works to decrease the production of different types of enzymes, including the COX enzymes. Ultimately, what you get is decrease of this TXA2, which is thromboxane. Thromboxane interacts with platelets and causes platelet aggregation, and so aspirin therefore inhibits platelet aggregation that way. Aspirin is acetylsalicylic acid. ASA is a common abbreviation used for aspirin. Often given as a baby aspirin, 81 milligrams, or 325 is the full strength, depending on the different diagnosis you have. Again, not going to be super important for your guys' practice, but if you do have people post-MI or post-CABG, they're going to be probably on an aspirin for the most part. General uses, if you're over 50 and have a 10-year risk, remember we talked about that omnibus risk calculator, again, not very useful for your patient population. People who are pre or post acute coronary syndrome are going to be on aspirin. Low risk people for anticoagulation, which is maybe where you're going to see aspirin used more often. If you have a patient who has a arrhythmia and is maybe at risk for or maybe at risk for a clot, we're going to talk about atrial fibrillation, which would be the case here. But and there's scoring you can look at too, which we're going to talk about as well. But people who are at low risk would be maybe candidates for aspirin therapy alone. If they've had a stroke or transischemic attack in the past, they'd be on aspirin usually as well. The side effects: increased bleeding risk. Aspirin's not the friendliest on the stomach and cause some dyspepsia, so we usually give enteric-coated aspirin, and it usually bypasses that side effect. Aspirin's pretty toxic in overdose. If you take a lot of them, you can have problems there, so that's one thing I just mentioned. Children less than 16 is contraindicated due to something called Reye syndrome, which is an encephalopathy likely associated with an immune reaction with viral illness at the same time, but it has been heavily associated with aspirin. So again, just something to think about. And then there's a stroke prevention product called Agrinox, which is a combination product, which I'm not concerned you know about, but I put it on there just for reference. P2Y12 inhibitors are listed here, and I'm not going to spend much time on these at all because, again, I really don't think you're going to see these on a lot of your patients. But clopidogrel, ticagrelor, and prasugrel are all the drugs here. These drugs are all used in conjunction with aspirin post-MI or acute coronary syndrome. So patients are going to be on both drugs to prevent platelet aggregation. The thing to think about here is the different types of physiology related to the different types of pathophysiology, I should say. So if you have a history of a myocardial infarction, a blockage in your coronary artery, that's really fast flowing blood. Blood's not pooling in those arteries. So really platelet aggregation is key to the initiation of the clotting process. So we really want to target that in those types of patients. Same thing with stroke. In the cerebral vasculature, the blood's not pooling there. Now, when we have people who are at risk for venous thromboembolism, like DVT, PE, or have atrial fibrillation, that blood's slow moving, it's pooling, it's clotting factor rich. So really, platelet aggregation isn't as important in those patients. And we're going to talk more about this with DVT in the next set of slides, but I just wanted to point out the difference between pathophys and how we're doing this. So in the off chance you do end up with treating patients who have acute coronary syndrome history and are on these medications, I think it is important to have some understanding of them, but for the most part you aren't going to see them come into play in your practice very often, I wouldn't think. This is a slide for your reference. It just shows the differences between the different P2Y12 inhibitors. Again, very common if you work in the cardiology world. If you don't, you aren't going to see these a whole lot. All right, moving on to the clotting cascade and moving away from antiplatelet drugs to anticoagulant drugs. The intrinsic pathway is meets the extrinsic pathway in the common pathway. So the point of all this is that there's a couple shared parts to this. So you have factor 10 and factor 2, between 2A and 10 to 10A. are your major clotting factors here. So it's really important that anything that's going to work well to inhibit the formation of clots, both intrinsically and extrinsically, you have to work in both. So if, let's say you just inhibit, I don't know, factor 9, which no drug does, but let's say it did, you would work with the intrinsic pathway, but if you had some sort of trauma, so damage to your blood vessel, you'd still be at risk for getting some problem as far as a clot goes that way if you aren't inhibiting these common pathways. So really, when we're looking at drugs, the point of what I'm saying here, they have to have 10A or 2A, and sometimes they have both of those as far as activity goes. So again, targeting common pathways is important for anticoagulation. Several products are available. You have fast-acting, short-acting, oral, IV, sub-Q, so you can really do a lot of different things with patients. Patients may be anticoagulated for a variety of reasons. So ultimately, you need to prevent a blood clot from growing or forming. So once a patient has been diagnosed with a venous thromboembolism or DVT PE, you want to give them anticoagulation because you don't want that clot getting any bigger. Anticoagulation itself doesn't dissolve clots. Your body will do that naturally on its own, but you need to help it a little bit, and you need to help that clot preventing from getting bigger. So you give somebody anticoagulant, their body can dissolve the clot on its own. We do have some clot-busting drugs that are much more useful in acute situations. So if somebody has an acute stroke, we use them. If somebody has a pulmonary embolism that's so big that it's causing them to actually go into cardiac arrest, which does happen, we can give them clot-busting drugs in the acute phase. But really, when we're talking about these drugs, these are not clot busters. They're often referred to as blood thinners in the general public, which doesn't really make a lot of sense either, but that's the way they've been described for years. They aren't thinning your blood at all. They're just making your blood less able to clot, which isn't thinning it. But that's just the way we've been describing them for years and years. So sometimes you'll ask somebody, are you on a blood thinner? Yeah, I take my Coumadin. Okay, well, that's a blood thinner per se. It really is an anticoagulant. So anyway, people may have a history of venous thromboembolism. So maybe you've had a patient who's had multiple DVTs in the past, or PEs, and they might be on chronic anticoagulation. So you might see either people starting it, taking it for short term, or taking it long term for prophylaxis. And we'll talk about that at the end of this lecture and go through some scenarios, or a scenario at least. All right, heparin's probably going to be the one you're more or less going to mostly familiar with. Heparin, what its mechanism is it potentiates antithrombin. So what happens is it complexes to 10A and to prevent the formation of thrombin, which is factor 2. It also complexes with factors 9 and 10 and prevents the formation of fibrin itself. So you have a couple different mechanisms heparin does. But anyway, focusing on 10 and 2 is key. So heparin's a very effective anticoagulant. Standard therapy for many conditions. It doesn't have a lot of contraindications either. You can give it sub-Q or IV. Sub-Q is usually given for prophylaxis only, but IV and sub-Q can both be used for therapeutic heparin. Sub-Q injections are a little bit tricky because they're for therapeutic use because it's really high doses, and it doesn't necessarily absorb the best, and it can be frequently dosed, so it's not ideal, but it is fairly inexpensive. So we'll talk about that when we talk about DVT treatment. Weight-based dosing, specific levels are targeted. Monitoring, we can monitor with APTT levels, anti-10A activity, and then adjusting the dose accordingly. So if you have a patient who's admitted to your hospital, and or if one of your patients gets admitted to the hospital with a DVT or PE and they're on heparin, what happens is, and if you've worked in some sort of at least moderately acute hospital as a nurse, you know this already. But when you dose heparin, a lot of hospitals, at least in Minneapolis, what we do are nursing run protocols, meaning that the provider will order a heparin IV therapeutic protocol. And so that means that the nurse will check the patient, make sure all their information is in the system. They'll run a protocol which will tell them how much to start with. And then the pharmacist will confirm that protocol, then it verifies it, and then the patient can start the therapy. So what this usually means is that there's some sort of a bolus of heparin given, and there's a continuous infusion effect or continuous infusion running. The effects of anticoagulation with heparin are immediate if given IV, and about 30 minutes if given sub-Q. So it works very quickly, which is nice. Half-life is very fast, 1 to 2 hours. Another nice thing about heparin is if you overshoot it a little bit, or if somebody starts bleeding, we don't want that to happen, but it is, of course, a risk with anticoagulants. Somebody starts bleeding on your anticoagulant, you need to stop it. So heparin's not going to stick around in the system very long, which is a nice thing about it too. You don't need to renally adjust heparin, which isn't a big deal in your population, but if you had a patient with renal failure, renally compromised, you don't have to adjust it for that. This is just a side note, kind of an interesting fun fact. Heparin is a quote-unquote natural product. It's extracted from the intestinal lining of pigs, processed and then fractionated. And then you have different types of products built from this. So you have heparin, which is a unfractionated version of this, and low molecular heparin, which is a fractionated version. Basically just a smaller version of the molecule. It's easy, expensive, it's got a pretty big risk of contamination, and the FDA has cracked down on some international production of heparin because it hasn't met the standards of what needs to be done. If you have patients with certain religious beliefs that don't want animal products or pork products, they might be resistant to heparin, which is a bit interesting itself. Heparin can be produced synthetically and via enzymatic reaction, but most of the time this is more expensive and difficult to do, and the cost doesn't change. So really the natural product is what we still use to this day, interestingly enough, although it's very purified and standardized. Besides bleeding risk, heparin has an interesting side effect called heparin-induced thrombocytopenia. This can happen to anyone, so I think it's important mentioning. It is rare, though. What it is, it's a time-sensitive thing and it's a platelet activation thing. So let me explain this a little bit more detail. So what happens is within 5 to 19 days in therapy, so there's a pretty big window of time here, you get a precipitous drop in platelets, so about 50% drop. So should be a big drop that happens fairly suddenly within that 5 to 19 day window. It's not associated with anything else. So patients shouldn't have, if they aren't losing blood, they shouldn't be losing platelets. So it should be pretty obvious. You want to stop the heparin immediately. You don't re-challenge patients for at least 100 days. Interestingly enough, this increases the chances of clotting, and that's correct because you might think about this as counterintuitive. So if you're decreasing your platelets, you would think you have an increased risk of bleeding, right? Because platelets help clot. But what's happening is you're actually activating your platelets all at once. So heparin forms these complexes with your body forms an antigen to it that complexes with the heparin that interacts with platelets in a way which causes them to activate, puts you at severe risk of clotting. What happens is, like in this picture here, people can get these areas of their body that end up with so many activated platelets that they get clotting off to areas which causes necrosis of the tissue. Now, this is a pretty severe looking case, but it does happen. The bigger risk, obviously this is nasty and we won't want this to happen, but the risk also is that you could have stroke and MI and all types of problems that way. So it's a very serious problem. We do have to treat it appropriately and treat somebody potentially with alternative methods if they have HIT documented. So again, don't re-challenge. It takes your body about 100 days to clear the antibody complex with heparin, and after that, you can consider re-challenging. Some clinicians will recommend never re-challenging somebody who's had HIT, but it is technically okay to do that. It doesn't necessarily mean once you've had it that you would have it again every time. It's not a guarantee. So, but it is a significant enough risk that you may not want to risk that. So it just depends. All right, low molecular weight heparins are enoxaparin, dalteparin are the two drugs here. Enoxaparin or Lovenox being by far the more common one. Similar action to heparin, but it's a smaller molecule. The incidence of HIT is much less. However, if you have a patient who's had a history of HIT, this is not an alternative you can give because it still causes or could potentially, potentiate the HIT that's already occurring. So we don't anticoagulate people with low molecular weight heparin who have the HIT history or have HIT antibodies. Best to avoid the agents altogether. And if you're wondering how you confirm HIT, you can actually run a test. Just so you know, you can run an antibody panel that tells you if they have HIT-specific antibodies. But anyway, back to low molecular weight heparin. They target factor 2 and 10. It's very similar to heparin itself. Usually you don't have to monitor these. So with heparin, we're monitoring fairly closely. We're making small adjustments to the infusion. With these drugs, the kinetics are very predictable. It's basically weight-based dosing. So usually it's a nice drug because it's easy. 1 mg per kg, Q12 hours, and that's pretty much all you do. And it really doesn't change for pregnant patients. And it's a great drug to use in pregnancy, actually, because it's fairly safe. And the dosing is quite easy. It is renally eliminated, so if you have a patient who has renal dysfunction, that would be a problem, but most of the time that's not an issue with young women, reasonably healthy women. So what we'd use low molecular weight heparin for is a couple things. Bridging therapy, so if somebody has a DVT, we might want to start them on a drug called Warfarin, which we're going to talk about, and this is going to be less relevant in your patient population, but again, we'll get to that. But what happens is sometimes our oral anticoagulants, like Warfarin, which has been around for a while, take a while to work. So we start with low molecular weight heparin because it works very quickly within an hour or two, and then they can be bridged until that Warfarin starts to kick in, and then you can get them off and then onto the Warfarin chronically. Now, the reason why we do this is because low molecular weight heparin is pretty expensive. If you see this product here, the way I have it here, this is what it looks like. It comes in a pre-filled syringe. That process is not cheap for drug companies to make. So even though Lovenox is generic, it's still quite expensive. Some people just can't afford it. So long term, don't like to use it, mostly because of cost. Also because some people really hate injecting themselves with stuff. So generally, if you have a fear of needles, it might not be a great idea. All right, so other things you can do, you can substitute it for heparin in most situations. Fast acting, it's not super fast acting, not as fast acting as heparin, but it does work fairly quickly. Not easily titrated, we don't monitor it, which might be nice not monitoring it, but you might not be able to tell if somebody's gone too high or maybe they're getting too much. You don't necessarily have a good validated method to test that. With heparin, we do. With heparin, we can check and say, yeah, they're too high, or yeah, they're too low. With this drug, our hospital actually has an in-house test we do to check for it, but I personally don't know if it's 100% validated within the literature. So take it for what it's worth. It's more convenient for patients for sure, but it's expensive, and you can't monitor it, and you can't titrate it. So. All right, how do we reverse these? What if we do go overboard or somebody's bleeding? There's a drug called protamine sulfate, and what it does, it combines with heparin or low molecular weight heparin to form a neutral salt. It takes about 5 minutes to work, and 1 milligram of protamine neutralizes about 100 units of heparin. So if you gave somebody 1,000 units of heparin, and they're bleeding now, which is a really low amount, but let's say you gave it to them IV. You could give them 10 milligrams of protamine, which hopefully neutralize it. The other thing is per milligram of enoxaparin, it's about 1 milligram of protamine. So if you gave somebody a dose of, 40 of enoxaparin, you'd give 40 of protamine. So it's pretty easy to dose that way. One thing to think about is that you can get rebound of the anticoagulant. So what happens is, especially with low molecular weight heparin, protamine doesn't last as long as low molecular weight heparin. So even though you neutralize a lot of it, you could still have some left. Same thing with heparin. There could be some circulating heparin, even though it's got a pretty short half-life, but it is possible you get this rebound effect of anticoagulation, so you might have to redose the protamine. Protamine can cause anaphylaxis, like reaction with infusion, cause bradycardia, and a drop in blood pressure. But ultimately, none of those things are as bad as having a significant bleed. So it's a useful drug in certain situations. All right, moving on to vitamin K antagonist, or Warfarin. I'm going to spend a couple slides on Warfarin. Warfarin's brand names are Coumadin or Jantivin. Warfarin is contraindicated in pregnancy, so we don't use it. So, this is going to be the patient who might be postpartum who could be a Warfarin candidate potentially, but for the most part, not a good choice in pregnant patients, and actually contraindicated, so not a choice at all. But we'll talk about it because you might see it, because even people in the postpartum period are definitely still at risk for clot, so you could potentially see patients on Warfarin. So final mechanism, it works by antagonizing vitamin K. We're going to talk about that on the next slide. Primary, long-term, this is the historical gold standard anticoagulant drug. A couple fun facts first. It's a super version of warfarin, are used as rodent poison. So you'll hear people say, I take rat poison. Sometimes older people seem to think this is funny, but it is sort of true, although warfarin itself is not used as rat poison. Vitamin K comes from the German word for coagulation, which is coagulation, starts with a K. That's another interesting fact. And there are several clotting factors derived from vitamin K. So vitamin K is responsible for the production of 2, 7, 9, and 10. 2 and 10 sound familiar. Remember, those are our primary clotting factors we want to target when we're giving anticoagulation therapy. It takes 5 to 7 days for full effect. I'll talk about the mechanism here in a second. Warfarin takes 5 to 7 days for full effect. So one of the things to think about with warfarin dosing is you do have to be proactive about bridging somebody with some other therapy, because actually when you start warfarin, people are actually at a hypercoagulable state. The reason is because vitamin K is also used to synthesize protein C and S. These actually act in the body as natural anticoagulants, and losing them happens within the first couple of days, and warfarin is actually more effective at depleting those quickly versus depleting the clotting factors. So it is important that's why we bridge with Lovenox usually when starting somebody on warfarin. Warfarin is hepatically metabolized via cytochrome P450 system, so there are drug interactions to consider. There are, however, no renal adjustments necessary. This is the mechanism of action of warfarin. And you can see that there's a lot of things going on here. Basically, the main enzyme is what's called vitamin K oxide reductase. What that does is it changes the way vitamin K can be used in the body so that it can become a precursor to different clotting factors. And warfarin, the active enantiomer S-warfarin, is the most prominent one, and that's the one that inhibits that particular enzyme. All right, so warfarin dosing is a little tricky. It's once daily dosed. I do want to spend a little bit on time on this in case you end up doing it, but the good rule of thumb, I think, for most patients, start with 5 milligrams and titrate the dose based on that. It's not uncommon for patients to be on a really wide range of doses. Some patients may be on like 1 milligram a day. Other patients may take 10 milligrams a day. Generally, younger, larger patients are going to need more warfarin, but that's not always true. People, you can get creative with your dosing. A lot of times people will take different doses, so they might do 5 milligrams Monday, Wednesday, Friday, 2.5 milligrams all other days, something like that. So you can mix up your regimen to make sure it works for the patient. Once you start somebody on warfarin, check labs 2 to 3 days later. And what we're monitoring for is something called the International Normalized Ratio, or INR. Generally, we're targeting 2 to 3 for any type of VTE. Prophylaxis, don't worry about that. You guys won't be dealing with that. It's more for like hip and knee replacement. They might do prophylaxis dosing. For mechanical valve atrial fibrillation, usually we target a higher one, which also probably isn't something you're going to encounter. Most patients will require once monthly checks once they're stable, but up until that point, they're usually going to be getting dosed anywhere or getting checked anywhere from a couple times a week to once a week, depending on how stable they are. Also, if there's acute changes, so if they get a drug that's interacting, that's something to consider doing a little bit more aggressive monitoring with. If they have acute illness, if they're nauseous and having vomiting and diarrhea, that can affect dietary vitamin K intake, which can also affect how warfarin works as well. We'll talk about those on the next slide here. Some patients might not have a reliable INR either. Depending on what's going on, there's something called, sometimes different things can affect this, but there's something called the lupus anticoagulant, which is a common thing we can test for. In that case, the INR is not really reliable. You can monitor what's called a CFX, which is basically a factor 10 activity level. And on CFX, the lower the percentage of active factor 10 you have, the more anticoagulated you are, if you want to think about it that way. So like with INR, a high INR means that your warfarin is working too well. So if you go above 3, 4, 5, 6, and so on and so forth, you're overcoagulated. With the CFX, if you're below 20, you're overcoagulated. So you got to think about it kind of as the opposite, but it's about percentage of activity of factor 10. With warfarin, some other general things I have to share about warfarin: don't load it. even though some of the guidelines might recommend loading people on warfarin, I don't recommend it. I don't think it works in practice. Warfarin is just a little bit slow to work. And if you end up, let's say, some people might have the mentality where thinking that you can give a high dose initially and then taper your dose down. Well, what's going to happen is you give that high dose for the first couple of days, the INR is going to usually spike, and you're going to have to drastically decrease the dose or hold the dose while that tapers down. And yes, you might get the person to a therapeutic INR faster. The problem is that you don't really know what maintenance strength they're going to be on for a while, so you're going to delay that time until you can get that patient on a steady dose. There's a lot of drug interactions with warfarin. Antibiotics is the biggest one, mostly because they affect the GI flora. All antibiotics do it. Some antibiotics also work hepatically and interfere with the metabolism of warfarin. But what happens is that if you decrease some of the specific bacteria, you end up giving someone diarrhea. That can decrease vitamin K absorption, and it's important for your body to be relatively stable with vitamin K absorption, and that's where we get to food interactions with warfarin. If you eat a lot of leafy green vegetables, that's a high vitamin K intake in the diet. That's probably one of the biggest sources. Now, it's really important if anyone's worked with warfarin in the past. I don't know what experiences you've had, but it's one of my pet peeves when people tell people not to eat green leafy vegetables. You can definitely eat them. The point is consistency in the diet. So keeping stuff regular. I mean, if you never eat salad and one day you eat a huge spinach salad, that's going to probably affect your warfarin substantially. If you eat a spinach salad every day with dinner, that doesn't matter. So keeping it consistent in the diet is really key. And I definitely don't like telling people to avoid things. Unless they never eat them altogether, then it's probably a good idea. Smoking increases metabolism of warfarin. If the patient's a smoker, it can make their general warfarin dose requirements higher. And alcohol may increase or decrease use based on how it affects the liver. Vitamin K is our warfarin reversal agent. So just like eating too much green leafy vegetables can decrease the efficacy of warfarin, vitamin K is something we can give to supplement it too. So usually it takes a while to work. It takes your body time to process vitamin K and convert it into clotting factors. So vitamin K is never, ever useful in an acute bleed if somebody's on warfarin. It's good for the follow-up, so you might want to give it right away. But just know it's not going to work. Usually at least 6 hours to start working, 12 hours for maybe halfway there, and about a full day for full correction. So if you ever give somebody vitamin K to reverse warfarin, you really need to be aware of the time frame. What happens, and sometimes a problem we run into, is that people don't wait long enough for vitamin K to work. And so they'll check an INR again maybe after 12 hours and it's still not come down to where they want it, so they redose the vitamin K. What happens is the patient may end up subtherapeutic for such a long time, because vitamin K will last several days in the body and sometimes weeks, causing a depressed INR, and then that really can mess with your patient's anticoagulation status depending on how long you want them to be in that low area for. If they're too low and it's too difficult to get them back into therapeutic range, that can be challenging, and you might have to bridge them with another medication like Lovenox or heparin. You can give it IV PO. There's different things to consider: bleeding, surgical procedures, can they tolerate oral? Doses are there. I strongly recommend avoiding 10 milligrams of vitamin K. Keep your dose it conservatively, and remember it takes a while, so just give it some time. Don't overdo it, and you should be fine with vitamin K. All right, I want to talk briefly about target-specific oral anticoagulants. Now, these are generally a new class of medication. So these are kind of billed as the warfarin killers, and there's a lot of studies that looked at whether they're better or not than warfarin. And what these drugs don't need to do is say that they're better than warfarin. They really just need to prove that they're as good as warfarin. Remember, warfarin's a gold standard with respect to decreased stroke risk with atrial fibrillation, decreased complications when it comes to DVT and PE or venous thromboembolism. So some studies looked at different rates of warfarin control. So, for example, some of the major studies that looked at these new agents, in their warfarin control arm, they looked at an INR goal of about 60% of the time, where your INR patients had to be in goal within 60% of the time. A good anticoagulation program can usually keep patients within goal 90% of the time. So there's some debate on whether or not that's the standard, but really, ultimately, when all said and done, it looks like these drugs are pretty good compared to warfarin, and they do essentially the same thing. There's no dietary restrictions with them, and it's important that we're going to talk about these drugs a little more, but the ideal patient would be somebody not elderly with good kidney function, relatively normal weight, possibly with poor access to regular lab facilities. The medications have predictable kinetics, so there's no monitoring needed. They get absorbed and eliminated normally with good kidney function in a linear fashion, so you don't need to monitor regularly, like with warfarin, where it's sort of all over the place. It's difficult to predict the dosing. These drugs are the opposite. It's very easy to predict how they're going to work. Now, if you're elderly or have a abnormal body weight or poor kidney function, that can change things. One of the big barriers with these drugs is a lack of reversal agent currently. We can't give vitamin K. Now, these reversal agents has come out for one of these medications and is on the way for the other one. So I'll talk about those in a minute. And again, no monitoring. Cost, also, these are new medications. Warfarin's old. It's relatively cheap. These new medications are much more expensive. And even when you take into consideration warfarin plus lab monitoring, these still are less expensive, or still are more expensive, than warfarin plus the lab monitoring that's involved. So as these come down in price, and in fact, I think they're not terribly expensive compared to some new medication, and a lot of insurances are actually starting to cover them. So this is a really common medication. That these are pretty common, and we're using them a lot more just because they're easier than warfarin. The other thing is, once you give them, as soon as they absorb, they work. You don't have to bridge somebody with these medications, which is a huge advantage. Okay, the first one is a direct thrombin inhibitor. It's called dabigatran or Pradaxa. It's approved for use in atrial fibrillation only, but it also has expanded indications for venous thromboembolism now. So that's kind of old. I should have changed that slide. It does have indications for use in AFib, and I'll say VTE here. It doesn't require monitoring. This was the first one to come out to challenge warfarin in 20, 25, 30, 40 years. I don't know how long warfarin's been around. This was really the first oral medication to come out to say, hey, we have an alternative to warfarin. So it was kind of a big deal. But there's a lot of questions about it. It's non-reversible. It doesn't have food interactions, which is good. It has some drug interactions potentially. But as this drug was on the market for a while, they had some more concerns coming out about post-marketing bleed risk, and I'm going to show you some comparisons here in a minute. The next group of medications are all the factor Xa inhibitors. Fondaparinux is a subcutaneous injection similar to low molecular weight heparin, like Lovenox. It's been around for a while. It's useful for bridging if somebody has a hit risk. So if you need something that's not oral that works quickly, this is a good option, but that's really all I'll talk about Arixtra. Rivaroxaban was the first oral factor Xa. It's got multiple approval of indications. Post-marketing bleed risk seems okay. And I think this one is the one that's getting used the most out of all these new ones. And we are seeing this used. For example, even a couple years ago, anyone who came into our emergency department with a DVT was getting sent home with Lovenox bridging to warfarin. Now almost everyone's getting Xarelto or Rivaroxaban, and it's been a big change of practice. It's a lot easier for patients to take. They don't have to worry about the monitoring, and it's relatively affordable. We still have to make sure that they can afford it, and the cost is there, but we're using it a lot more frequently. Apixaban's the other one I'll talk about too. Shows good evidence in AFib, also approved for other things too. Best safety profile probably per clinical trials. It's been shown to maybe have the lowest bleeding risk out of all the agents. There's another one that I didn't include on here, and there's some other Axabans coming to the market, and I'm going to show you some comparisons here in a second. Important to know, these medications have been approved in Europe for several years and then crossed over to the US. They're approved a lot for post-hip and knee replacement and some other indications like that. All right, so some comparisons about these. I'm not going to spend a lot of time on this. You can look through this if you care about it. But basically, you can look at the difference in dosing. So Rivaroxaban, Edoxaban's the other new one that's on the market now. But Rivaroxaban is daily dosed, which is kind of nice. You can debate whether or not you really should be dosing it daily, but that's the reason it is. One thing I'll point out that's probably on your mind is, can you use these in pregnancy? Why am I even talking about them? Current recommendations don't recommend using these in pregnancy. They recommend doing Lovenox usually, or heparin, and those are the ones that have proven safe. So the question is, apixaban being a category B, they actually did some animal testing to show that they couldn't prove any teratogenicity. They're really going for that market, but we don't know enough about it. And I don't think many people are going to be all that thrilled about prescribing it, because again, it's probably not well vetted at this point. Now in the future that could change, and I'm guessing that's the company's angle, that they want to get one that's approved in pregnancy. So this is since VTE is relatively, at least patients are at quite high risk for VTE during pregnancy, it is something to expect. So having an oral option to challenge warfarin, so somebody doesn't have to inject daily with enoxaparin or heparin, would be quite advantageous for a market share. So this is a drug that we could be watching. And if I were you guys, I would keep your eye on apixaban or Eliquis. That might be one that we end up using here. This slide is just to show some outcomes comparing things to warfarin, and most things either looking at the doses were comparable to warfarin or had a lower risk overall than warfarin. So not a huge deal here. What I want to show here with DVT and PE treatment, you can see these are bleeding risk. For the most part, major bleeding events went down when compared. So if we compare, oh, actually, sorry, I want to go back to the other slide here. Here, life-threatening fatal bleeding. This is what I want. Major bleeding, everything either was the same as warfarin. Apixaban, lower bleeding, edoxaban, lower bleeding, and edoxaban also with this dose was lower bleeding risk as well. Hemorrhagic stroke risk was substantially decreased across the board, the exception of apixaban versus aspirin, but that one doesn't really count. We don't care about aspirin, we care about warfarin. Life-threatening fatal bleeding, again, mostly decreases here. GI bleeding, mostly a decrease. So pretty good results overall with lower bleeding risk with these agents. All right, so just to summarize it, our advantages: you don't have to get your INR checked. There's no diet restrictions, less severe bleeding, fewer drug interactions. Pre-op management is easy, which, you know, it's you can look at it from that standpoint of that you just don't have to bridge with this medication. And if you were bringing somebody in for a potential procedure, holding it's a lot easier too. You stop it, it's out of the system by the time the next dose is due, so the next day. And then you can just restart it as soon as you need to, and you're good to go. Again, no bridging needed, which is really nice. Warfarin had this big, long, messy way of doing stopping before a procedure, bridging up until a certain point, stopping, bridging, starting, then bridging again until your warfarin is therapeutic. And it was just, it's frustrating for patients and providers because it's not reliable. This is a really reliable, easy system. Disadvantages: cost being a big one. If you don't have good insurance, might not be able to afford these medications. Not approved for all indications yet, but they're gaining improvements. Compliance: this is a really important one. If somebody's not adherent with these medications, they don't last a long time. If you miss a dose of warfarin, it takes days for your INR to respond, sometimes at least a day. If you miss one dose of this, you could potentially be totally out on anticoagulation for a time period, and that could put you at serious risk for a rebound vascular event if that's what you're taking it for. So the people who take these have to be fairly competent and adherent patients. Discontinuation rates actually in the trial seem to be higher than the warfarin, and I'm not sure about this. I think Pradaxa, dabigatran specifically, had some significant dyspepsia-like reactions with it that people were experiencing, so that might be part of that. Dose adjustments needed for renal dysfunction. You don't have to do that for warfarin. So for patients who are on dialysis or have severe renal dysfunction, warfarin's still going to be the major drug we're going to use. And this, I'm not going to ask you any test questions about the specifics of these drugs or anything about them, actually, other than just knowing that there are reversal agents available. This is a new one that just came out that was approved this last fall that can reverse dabigatran specifically. That's the first drug that is available to reverse one of these new agents, which is a big deal because a lot of people were getting really, I guess, apprehensive towards prescribing the new target-specific medications because they didn't have a specific reversal agent. And now we have one for this medication at least. And there's another one coming out for the factor Xa inhibitors. So we should have one reversal agents for all these new agents. The thing is how exactly are we going to use them? These have gotten very fast-tracked by the FDA, so the trials aren't huge. We don't know a lot about them, but they haven't seen many problems with them, and they've seen a pretty decent response. So it'll be interesting to see how these end up getting used. They're going to be very expensive, but think about these in the instance of a life-threatening bleed. So patients bleeding into their head, we're going to want to use these medications. So it's a good option to have. It'll just be interesting to watch and see how that ends up getting utilized in practice. Other reversal agents, fresh frozen plasma is something that can be done for warfarin patients to get an INR below 1.8 or to 1.8. It's very difficult to get an INR much lower than that. So you also need a large volume of fluid, and it could be problematic to get that much. And there's another medication called PCC, or prothrombin complex concentrate, and this is a very fast acting. Basically, it's like giving somebody clotting factors intravenously, that's really what it is. And it's used for warfarin reversal, but there are some indications that it does work for some of the factor Xa inhibitors as well, and we do use it for them because, again, right now on the market there's nothing for that. So this is better than, at least we can give them some clotting factors that work, even though they still got the circulating medication around. So that's all I've got for that. This is a review slide, and I just encourage you to think about how you treat a deep vein thrombosis or pulmonary embolism. I mean, that's probably what you guys are going to see mostly, as your patient populations are going to be at high risk for venous thromboembolism. So how would you treat it? I talked about several options. If you want to pause and review and think about it, you can do that right now. Okay, if you haven't had time to review, you might want to pause it and go back. And I'm just going to walk you through how I would do this. With a DVT or PE, with a pregnant patient right now, all you would need to do is heparin or low molecular weight heparin, and they'd have to be on that basically indefinitely throughout the pregnancy. Now, if they aren't pregnant, you have a lot of options at your disposal. So a non-pregnant patient, you could do a Lovenox bridge to warfarin, which is the old standard, or you could do one of the new oral anticoagulants. As far as lactation goes, I don't think we know enough about the new oral anticoagulants to really have a firm recommendation, whether how much they excrete into breast milk or whether one's better than the other. But as more data becomes available, we'll have more recommendations with that. So it's not terribly complicated. As far as duration of treatment goes, what we want to do is look at treating most patients probably about 6 months for their first event. And then after that, if they get another recurrence, then they're looking at usually lifetime treatment. But it really depends on the patient scenario. So with that, we're going to talk about arrhythmias quick. All right, so definitely feel free to pause and take a break if you want. I probably should have split this up into two, but here we go. I'm going to go through these antiarrhythmic drugs fairly quickly because there's a lot of them, and I really want to get to the arrhythmias in pregnancy and point out some of the treatment strategies we're going to do, because I think that's going to be more, of course, what you're considering. Most of your patients, if they aren't pregnant, probably aren't going to be at high risk for arrhythmia. It's going to be unusual, so that can be a big deal. We're going to talk about the different phases here and how we treat with the different drugs. If you want the visual aspect, you can come back to this slide and look at it, because it's a nice way to show our different ones. So we can see like sodium channel blockers. We're going to talk about potassium, calcium, and beta blockers as well, have all antiarrhythmic properties. All right, so phase 0 is your rapid depolarization, and you can see the different things there. Again, I'm going to go through this pretty quickly. So, heart anatomy. Here's some different descriptions of it too. So if you want to look at this and compare it to the diagram to get the visual plus the I guess the words if you want to read it out loud that way. But again, I'm going to clip through this pretty quick. All right, so class 1 are sodium channel blockers. Class 2 are beta blockers. Beta blockers aren't really antiarrhythmic drugs, but they have, because of the way they work in the heart, they technically are. Class 3 are potassium channel blockers, which are, and class 4 are calcium channel blockers. So calcium channel blockers that work in the heart are going to be, back to our hypertension lecture, are going to be like diltiazem and verapamil. They're going to be our non-dihydropyridine medications. So how do we use these? Well, any arrhythmia, we can consider giving different antiarrhythmic drugs, and we're going to talk about some of these specifically, but let's talk about the drugs quick and go through some examples. So quinidine, procainamide, disopyramide, or pyramide, excuse me, are all medications that can be used. There's variable uses for them, and again, I'm going to talk about the specific ones used in pregnancy because I think it's more relevant. I'll mention lidocaine really quickly. Lidocaine is used during code situations as an alternative, so we can give this for people who go into a pulseless ventricular fibrillation or ventricular tachycardia, but otherwise not used very frequently. Propafenone and flecainide are 1A, 1C antiarrhythmics. The 1C is specifically flecainide. Has a really nice side effect profile, and it is one to keep in the back of your mind. It's one that could be used in pregnancy, and I'll mention that in a few slides here. Amiodarone is, now we're getting to our class 3. Class 3s are probably the most potent group of antiarrhythmics, the potassium channel blockers. Amiodarone actually has all classes of activity, but it's primarily focused on class 3. It's a very powerful drug that works quite well. One of the biggest problems with it is it's got long-term toxicity, especially pulmonary fibrosis, can cause thyroid toxicity, neurologic toxicity, some ocular issues too. Lots of problems with amio long-term, but it's a very effective drug. It's got a really long half-life. It's got a ton of drug interactions. It can be given IV NPO. Again, very effective, useful in heart failure patients, but not going to be utilized very often in young patients because of its chronic toxicity, and not going to be used often, if at all, in pregnant patients, unless you really can't control the arrhythmia with anything else. It's kind of a last-line option. I'm just basically going to skip over these because they don't really have a lot of role in pregnancy. Again, they might be pursued if there was some sort of problem with the standard therapies we know are okay in pregnancy, but for the most part, probably not going to be used. Now, if you had a patient coming into your clinic who already was on medication for AFib or whatnot and was trying to get pregnant, that'd be a different story. With that, you might just have to, I would definitely recommend a cardiology consult and see if they would recommend either keeping them on the Digoxin and going forward with a pregnancy, or switching them to a more pregnancy-friendly medication. That'd be a good conversation to have with a cardiology consult. But as far as use in pregnancy, it's not a lot of information out there on these drugs. Sotalol is kind of a beta blocker, hence the LOL ending, but it also has a potassium channel blocking property as well. Going through this stuff. Dronedarone, it's another drug. Don't worry about it too much. Magnesium, if you give high dose of magnesium, you can get people out of torsade du poing, which is a ventricular tachycardia. You can see here on this rhythm strip how it kind of looks. It's kind of got these wavy looks to it. Adenosine is a medication that can be useful for supraventricular tachycardia, or SVT, which is the most common arrhythmia seen in pregnant patients. We're going to talk about the treatment there, but what it does is it blocks the conduction time through the AV node very briefly and interrupts your reentry pathway. So essentially what happens is the heart stops for a very brief couple seconds. Adenosine's half-life is really short, so it gets wiped out of the system very quickly, but it can be used to convert people out of SVT. Digoxin I want to mention briefly. It's a cardiac glycoside. It inhibits potassium sodium ATPase in the myocardial cells. It's not an antiarrhythmic, but it is useful in pregnancy. It can be given, and it is a good rate control agent. So there wasn't any other place to mention. It's mostly useful in heart failure normally, but I did want to bring it up because it is recommended for use in pregnancy occasionally. It's renally adjusted, which usually isn't a big deal. Digoxin also has pretty high toxicity, so you can monitor levels on it. But for most patients, if you take the standard dose, it should be fine. You can monitor the serum concentrations initially and just make sure everything's good. I've got pictures of foxglove up here because digoxin is derived from the foxglove plant. And then this is my fun fact for the lecture if you stayed with me all this time. Van Gogh was thought to have possibly overdosed himself on digoxin at some point. The reason is that this is a portrait of his physician, whose name I forget, but the physician's desk has foxglove on it. And interestingly enough, there's some theory that Van Gogh either took digoxin for mental health issues, which they thought might have worked at the time, or maybe had some cardiac issues. And the other thing is he went through this yellow period, and people who take digoxin, even if they're very slightly toxic on it, you can get blurry or yellow tinted vision. And there's a theory that Van Gogh actually might have overdosed himself slightly on digoxin, which is why he has a fair amount of work within a similar time period that's quite yellow. Now, that could be totally bogus, but it's kind of a fun theory to even discuss or think about. So anyway, let's talk about arrhythmia in pregnancy quick and where these drugs matter and where we might use them. So why do we get arrhythmias in pregnancy? Well, you get a lot of hemodynamic, hormonal, and autonomic changes due to pregnancy state that puts people at slightly higher risk for arrhythmia than they would be otherwise. Otherwise, we're talking about relatively healthy young women for the most part. So are they really at high risk for arrhythmia? No, but it does happen. And if it does, supraventricular tachycardia is going to be the most common one. Vagal maneuvers is the first line therapy to get somebody out of SVT. So bearing down like you're going to have a bowel movement. Carotid massage can work too. Blowing through a straw maybe. Those are the most common ones that I hear. Adenosine IV, we talked about that. So giving IV doses of adenosine. You can repeat adenosine a couple of times. If somebody is not responding to them, you can try IV beta blockers to try and slow them down. If somebody keeps coming in and out of SVT during their pregnancy, and maybe they can convert out with vagal maneuvers, but it's getting kind of scary when, SVT is fairly fast. So if your heart rate shoots up to 150 or 170, it's going to feel probably a little bit traumatic. So prophylaxis may be indicated. You can give people oral digoxin, oral beta blockers like propranolol or metoprolol, verapamil, and then antiarrhythmics like sotalol and flecainide have also been used in pregnancy. Caution, beta blockers, even though labetalol is one of our drug of choices for hypertension, generally some beta blockers have been associated with intrauterine growth restrictions. So that is one thing to just watch out for. How would we use these? Well, you'd usually start with something for rate control. You probably would reserve sotalol and flecainide for maybe more severe cases since they're more powerful antiarrhythmics. Another arrhythmia that affects pregnant patients is focal atrial tachycardia. It's what it sounds like. It's basically an atrial-related tachycardia. It's very rare. Treatment is essentially very similar to SVT. If you had a resistant case, you could go to amiodarone in those patients. And then atrial fibrillation, also quite rare during pregnancy. Cardioversion is the choice of treatment if somebody isn't stable. So if the patient comes in and they're hemodynamically unstable, want to sedate them and try and use electricity to get them out of the rhythm. And that would go for somebody who is stable as well. If somebody is stable, just went into the arrhythmia and comes in, usually electricity is going to be the best option for them to get them out of the arrhythmia. If they've been in the arrhythmia for usually what we say is 48 hours, you can be relatively certain that a clot hasn't formed. So just to explain this a little more, what happens is that when the atria aren't beating relatively, they're basically fibrillating, right? So they're just quivering. The blood pools in them, causing clots. And if you converted somebody out and the atria start pumping normally in sync, you can end up throwing one of those clots into your circulation, which can go into your head, usually going to have a stroke. So with AFib, we want to make sure people haven't been in it very long, not long enough to really form a significant clot. A lot of times what we can do is a transesophageal echo, which gives imaging to see if there is a clot in the atria. If that's good, then we can go ahead and get people out of it. But if somebody comes in and they're very unstable, we'd use electricity very quickly. Other strategies we can do if somebody comes in an AFib, we can try and rate control them using digoxin IV or verapamil or diltiazem IV. Both of these medications can work. Digoxin's kind of old school, but it does have more data in pregnant patients, seemingly, than some of the calcium channel blockers. However, most patients would probably get diltiazem. It's the one we use on pretty much everyone. It's a very nice titratable rate control agent. So we can slow them down with that. Sometimes just rate control enough will convert people out of AFib. So if they just went into AFib, bring them in, get them rate controlled, they might convert out of it. If they don't, what we might do is send them home on anticoagulation. So we might give them either heparin or low molecular weight heparin, again, not using any of our other anticoagulants because these are the two preferred in pregnancy. And then bring them back in for electrical cardioversion or consider pharmacologic cardioversion. Cardioversion pharmacologically can be done with quinidine. That's the historical one. However, quinidine has been difficult to obtain. I don't think many companies make it anymore. So flecainide is usually the drug of choice for pharmacologic conversion in pregnancy. You could do amiodarone if you needed to, but the idea is hopefully that flecainide works. So the time frame with this, just to review, somebody comes in, they've just gone into AFib, you try and convert them out of it. You can usually do that successfully. If you can't do it with electricity, you try pharmacologic options. If they've been in AFib for 5-6 days and they come in, the best thing to do is rate control them, start them on anticoagulation, bring them back in a few weeks, 3 to 4 weeks, and then either try and use electricity cardiovert them or give them pharmacologic options for cardioversion. And that's really the three major arrhythmias in pregnancy. I don't have much else to say about that, and I didn't want to spend a lot of time because I don't think it's terribly relevant. I think most of this is quite rare. And really, if you see arrhythmia, it's going to be the SVT. So hopefully this was helpful. If you have any questions, email me, but that's it for this lecture. Thank you.